time they complain, the effect will have been gone. Most of the complaint, number one is bruising. People don't normally complain about bruising if the nurse knows how to stop the bleeding. Immediately when they pull out the needle, there's a bit of spot. Even it happens to me. I can't say I don't bruise. And immediately I just put the pressure on and wait for 45 seconds to 1 minute. And then I just continue. While I've got my finger there, I'm actually injecting other points as well. So I don't stop. I don't wait for 1 minute and do that. So that's the most common sort of complaint if the injector is an amateur. And the second most important complaint, actually this is probably the most important, is patient dissatisfaction. It is not to do with the number of units. And if you join my Facebook group, ASI, doctor's Facebook group, in fact, I'm going to post a lady who had frontalis done, and then she's got this very heavy corrugator now. Because you're only prescribing, I don't actually expect you to remember all this. When in times of trouble, you ring either your clinical supervisor or Richard will tell where, or you can ring me direct. So I'm always here for you unless I'm traveling. So this has to do with suddenly, this is all the frontalis is flat, is what you want, but suddenly because they are not injecting the corrugator, it becomes like a bump in the corrugator. So this is the effect I'm talking about. And when you inject the masseter, if they inject wrongly, the smile goes funny, they go awry. So they go funny. Again, it's only temporary. Or the other one is when they inject the masseter and the bulge is bigger than what it was before. That's to do with paradoxical, it's to do with the technique. So you don't really, you can do same amount of damage with just 2 units of toxin versus 20 units of toxin. So it's not the overdose, it's got to do with anatomy. It's got to do with whether they are accurate or not. But like I said, it has to do with understanding the facial muscles, and then all these complications I've told you has happened to me personally. So it is not as if it is something you just need to write it and say, okay, this is the problem, this is what we're going to do. So most times you don't need to do anything other than patients screaming, I'm not happy, these are all what we call PIA. So just for a matter of, you're not clinical, but in aesthetics, we have 3 categories of them. We got a PIA, which is pain in the ass. Those patients one this, one that, one that, that. We got red flags, which means, I'm not happy with last injector, and I'm not happy with this, I'm not happy with that, I'm sensitive to numbing cream, I'm sensitive to this. That's a red flag. Okay, so I have a team of more than 20 staff in my aesthetic clinic, and even yesterday, as late as yesterday, I got caught with one of the red flags, one of the nurses injected, right? She's so super experienced, and yet she got caught. Okay, so this, you are at the other end, and the other one doesn't apply to you, is waste of effing time. Those people ask so many questions and say, okay, I'll think about it. So those we want to identify very quickly and say, the price will be so much, and get out the door. So but the main one is that you really want to get rid of the PIA and the red flag, and you identify early rather than chasing, say, look, I can do a deal for you and all that. That is a red flag. Okay. So any questions regarding toxin? So this is quite an interesting industry, yeah.
There's an interesting. Some patients have tried Botox in the forehead and they said I get no result. You try it, no result. Have you ever come across that where there's no effect?
In 20-something years, I've come across with somebody who has developed antibodies to all three.
Yeah.
So it does happen.
Yeah.
So it can happen. So that we will try all 3 and none of them work. But sometimes it's even in our own clinic, we just have to hush and just give some more, and sometimes maybe underdose, maybe expired, whatever, too long, taking out too long, and all that. We don't know the whole chain. If it's the first time, we say stop, then we just keep our mouth shut and just do it again. And happen again, sorry, you're definitely one of those who are. So in our new consent, we have warning there in the new consent that they can develop antibodies to the toxin, or even if it's the first time, they may not respond. It's not a problem. It's just a medicine. So maybe you want to tighten up in the new consent and say that, but if you don't run the business, you don't have the problem. We do. So we don't want them to keep coming back and asking for more. So that's one thing. So any questions regarding toxin?
Also with patients, I've had to deny a couple in my own clinic who have hooding or blepharoptosis.
Yeah, hooding. Yeah.
And I've had to say, look, I can't give you a full dose. I can only give you a small glabella dose, and then come back in 2 weeks' time, and we'll do it again if.
Very good, very good. So most nurses and doctors who are new to this area cannot differentiate between a brow drop and an eyelid drop. So you have definitely identify it. Like I had a ptosis, partial ptosis, and I have hooding. So there's no way injecting my eyebrow is going to lift it. Again, this is to do with patient dissatisfaction and picking the wrong candidate to inject. So yeah. So it's not, if you inject, you drop the brow and patient's not going to be happy. Commonly, I have seen the last 2-3 weeks, and people inject them before wedding, and everything always goes wrong just before wedding, right? So they change the way they look, and my God, so it's my policy never to inject anyone within 2 weeks of wedding, because they expect perfection like on the day, and it's too late to fix anything on that day. You just have to ride out for 6 weeks. So it's my policy not to treat anyone 2 weeks before wedding. It's to do with patient dissatisfaction. Main thing that is the main concern with toxin. You're never going to be sued. It's to do with patient dissatisfaction rather than complications. All the rest, funny smile and all that. Look, it's just they're very trivial, but it's not so trivial to certain type of patients. So you just got to contact clinical director or me, and I will write you through it. I will help you sail through it. It's usually not a problem with toxin. It always happens to someone once, I can tell you that. It's happened to me 3 or 4 times over 25 years. So,
With the crooked smile, with Risorius.
Two anterior. They're two anterior.
Yeah. Oh, okay. And how long would that last if they were to have a crooked smile?
6 weeks. Average. Everything is about 6 weeks. Depends on the dose and things like that. Yeah. But it's before a wedding, they're never going to forgive you, okay?
Well, no, because I had to inject a masseter yesterday, and she happened to be a model, a face model.
Yeah. Can I actually explain? Why is it that doctors don't get proper training? And they just go to the Gauderma and ask them to show it? You should get proper training. I'll explain to you later why. Okay, yeah. So, when we advertise for a course, it's usually 20 nurses asking for it and not one doctor asks for it. The doctor seems to think that they know the anatomy, but I'll explain to you why later. It becomes crucial when you face APRA. Okay? So APRA doesn't look at Gauderma as a trainer. They are only facilitator for their product, and they will tell you firsthand. They don't train you anatomy. They can't train you injection. They only show the product. It's like saying, prosthetic, somebody selling prostheses. They just say, this is what we're going to show you. This is what I recommend it, but we're not here to train you. You should know it yourself. So just be very aware, and that is APRA. Okay. So any other questions regarding toxins? No? Okay. So today, we're going to talk about the most dangerous complications, high-risk areas, and common complication with my case study. Myself got involved. It wasn't my case, but it was referred to me. What you are expected to know. What you are expected to know by APRA and your insurance. Other complications, those are easy. And I want to explain the HCC and APRA process, and that is part of my case study. Like what you expected to know, what you should know, somewhere duplicated. I'm being known to a lot of people. When I teach cadaver in USA and also in India and also in Australia, cadaver dissection for anatomy, there are 18 areas of injection. So, and here comes the problem. When complication gets reported, we often do not know the anatomical description, because there isn't one. It's only descriptive. There isn't a nasolabial fold. Everybody understands. You know, when you talk about lateral cheek, are you talking about area 14, which is subzygomatic area, or are you talking about area 3, which is a lateral cheek, or you talk about area 4, which is anterior cheek? This whole area is a cheek, so it is difficult to, when your nurse asks for to inject a certain area, you should know exactly what area they're talking about, because a lot of the advanced areas around the eyes, I don't expect them to know, and they get confused between a tear trough and an anterior cheek. That has to do with the training. Tear trough, I won't go into detail into it. Not many of your nurses inject tear trough. Tear trough is number one area for complaints. It's to do with anatomy. It's to do with patient wrong selection. So overall, let me explain to you that there are 18 areas of injections that we have to go through, and each one has a specific technique, and each one has different danger. For example, if the nose, you can see 6, 7, and 8, which is dorsum of the nose, tip of the nose, and the nasal spine. So, and when they say I inject nose, you got no idea what they're injecting, and each one requires different technique. And when it comes to blindness, we got no idea where they injected because they just say I inject the nose, and that is a problem with marking the history. So I don't expect your nurses to inject the nose, and we pay particular attention. If you inject the nose, we want to know whether you know the right technique and the different technique, so that when something happens, you know what's gone wrong. This year, there's been 2 cases of blindness. It reported to Sydney Near Hospital, one from Tasmania, one from Sydney. So within 5 months, we got 2 cases.
Cheers.
So not all areas are risk exactly the same. In general, the most central part is the highest risk. There is a reason for it. There's a reason for it. So if you just here, I'll just quickly highlight the 3 areas: the nose, the forehead, and the temple. These are the 3 highest risk areas. Now here, we don't inject the nasolabial fold, which is commonly injected, and you will see a case afterwards. It can cause severe damage. The tear trough is also considered as high risk, and anything around the eye. So it is not, when they talk about filler, it's not exactly risk-free. So it needs to do with the area. And the lips, they say, oh, how is lips moderate risk? Well, you'll see my case in a minute. So you must be aware that all these 18 areas, each one require detailed training, and it is because if you're just 2 millimeters out, you're going to ask for trouble. They're all different techniques and all different dangers here. So you probably didn't know, the most important complication, the worst, is actually a stroke, hemiplegia. Okay? So that is in the temple, in the forehead, and the nose. Again, there's highness. In the whole world, globally, there aren't that many, but it is definitely one of the worst. Nobody's died yet. But hemiplegia, to do with the embolus to the middle cerebral artery, that's injected in one of these areas. We don't know how, because when the complications reported, we actually don't understand their technique, and nobody is there to video it happening. So it's to do with the depth of the needle, not the area, but the depth of the needle, whether in the right plane. So what we most fear in Australia, other than CVA, is blindness. Okay, so if you go blindness, it goes very loud across the industry, because we are still trying to work out a protocol regarding what to do with blindness. So that is why the thing is there. So the module is there. Skin necrosis is probably the most common, most severe under these 3. It's probably the most severe skin necrosis caused by blockage of the artery. And bruises is by far the commonest complication, yeah? Bruises and patient dissatisfaction. These two are by far the commonest complaints, bruises and patient dissatisfaction. So and then of course the rest, migration and granuloma, that's to do with technique, and migration is fairly common too, depending on the technique. Granuloma, I've never seen one. It's obviously reported in the journal, but in Australia we haven't seen one reported, because if one is being reported, it usually comes to me. I normally hear it, and because normally people come to me before they ask anybody else. So let's recap. From your point of view, stroke is the worst of all. Blindness, you definitely want to be in the consent, where you inject in the nose, in the temple, in the forehead, and also the nasal labial fold. I'll show the circulation in a minute. Skin necrosis is very hard to treat. So is blindness and CVA. Bruises and patient dissatisfaction, they all sort of go hand in hand. This is when your APRA process starts. So these four areas, nose, temple, and nasolabial fold. A lot of people think they know how to inject the nasolabial fold, and this is why we see the most common severe complications come from nasolabial fold injections, simply because people don't understand the anatomy. So we're not going to talk about the anatomy, but here you need to understand the circulation. So from the lip up, there's this angular artery that leads, facial artery, this angular artery. You can see the superior labial artery when your nurse injects the lips. It can backflow into the facial artery, then it goes up to call the angular artery, and then it leads to the ophthalmic artery. So you can see from the temple, there's also a branch of the frontal branch of the superficial temporal artery. It goes via the supraorbital and the supratrochlear. So they all interconnect, and that is where the blindness comes from. So most of it is upper part of the face. Remember I said temple, nose, also nasal artery. They all connect to end up in the ophthalmic artery. So that's why it causes blindness. So around the eyes and all that, right? So and the nose area. So the nose is probably the commonest one to cause blindness. Is least reported in China because every day millions of doses of nose being injected, but their reporting is not as good, not shared. In Asian countries, this Asian is number one. So, but you see that the nasolabial fold here also causes problem, and so is the lip. I'll show the case later, which I got involved. It's to do with injecting lips to go back all the way and cause necrosis here. But theoretically, and it's happened, injecting the nasolabial fold can cause blindness because of a direct flow. So nasolabial will go there. We haven't seen any of the case of the lips flowing back to cause blindness. That one we haven't seen. But nose injection causing necrosis this area is what you're going to see next. So this is the mechanism whereby the injection upwards within nasolabial fold injection. The nose injection, well, we actually don't want to inject there, but here the tear trough, injecting the tear trough here, and the nurse or the injector is not aware of the angular artery and go too close to the angular artery. So bingo, you get a blindness there, okay? And of course the glabellar area, forehead area, this is forehead area, how low, the lower you get to the orbital margin, the higher the risk. And then the frontal branch, which is here, which goes all the way here. But strangely enough, if you follow my Facebook group, Doctors Group, I posted an ultrasound studies on this one. You know how big these arteries are in a living person. I say living person is because in cadaver we can't see them because they all collapse. So if I do ultrasound with Raquel, do you know what's the average size of these arteries?
I don't know, 2 millimeters, 3 millimeters.
Yeah, you think it is, right? They're all under 1 millimeter.
What? Oh my god.
Yeah. So I am intrigued as to why 1 millimeter vessel would cause this sort of problem. I actually don't understand how you squirt a filler and get into this sort of problem. So,
Do you think you'd still get blood supply from the other anastomose?
very, very good question. So, you know that even though this area here, glabella, when we inject, it is one of the places that cause a lot of skin necrosis in here. And yet when you do skin surgery and you can cut right through to the bone and you stitch it up, nothing happens, right? It heals perfectly. You can slash it right down. You can cut even the facial artery into half, and yet it will heal perfectly. And it somehow has to do with the collateral circulation. It all comes in, and this micro circulation makes it very, very easy to perfuse the area. And yet, if you stuck a filler right in this part, in the facial artery, inside the facial artery, we can understand an embolus being shot off and go to blindness. But if you actually block the facial artery, somehow, I still don't understand this, you get necrosis. So I have to ask one of the plastics. I keep asking, I don't get an answer. So it's very strange. You can cut the facial artery across, and you don't even have to stitch it up, and everything heals. And yet, if you put a block of filler there, and the whole area goes blue, white. So anybody has any idea?
Maybe a spasm.
Yeah. Or it's more of a pressure effect rather than actual occlusion.
Okay.
I think solely by occluding a vessel, you may cause some problems with the collaterals. Usually come in and replace that blood supply. But if you have a volume issue where you're blocking venous supply as well, then you've got a chance for ischemia.
So does that mean that the filler would also have to block the veins
as well? Both veins and arteries. I think so.
Yeah. So I've never got it's certainly possible, but it's just that you can cut the facial artery and the rest will just go through. But yet you can't put a block of that's the theory anyway. You can't put a block of filler right in the facial artery, and that seems to cause necrosis. So it must block other things or cause something else. So that's an interesting thing that we do. So the stroke, this is the worst one. So it is obviously from the nose. From the nose will be the dorsal nasal artery, and in there. So I don't think you script any nurses with nose, right? No. Do you script any nurse doing nose?
No.
Yeah. So there are areas that you don't script. So temples.
Okay, good, because I think that was one of my questions I wanted to ask. I would be very uncomfortable ticking yes to a nurse trying to put injectables in these dangerous areas.
What?
No, we don't do
noses. Are we allowed to say no?
You have to say what is dangerous areas.
Well, the glabella, nose, temples, and nasabial folds. If a nurse says, "Oh, hi, doctor, I want to inject here and here," can I say no? It's not safe. I'm not going to approve of that because I wouldn't be comfortable with it.
We don't script for noses. We'll only script for temples when it's a really experienced nurse.
But how do we know if they're experienced or not if we're getting so many nurses come through? And I think that was my own.
If a nurse comes to you and says they're going to do temples, you'll rarely get a nurse that comes through and says temples. You can say, okay, what training have you had for temples? Have you done temples before?
Okay, I'll leave the administration for another time. But you have that part doesn't concern me. But let's touch on the base of temple, just for your knowledge anyway. Dr. Dong may want to know something about the temple. There are actually 3 different planes to inject the temple. Without boring you, there are 3 different planes. Most of them inject in the superficial fat plane, and that area is actually the area is technically the safest, but practically speaking, is the worst result that you ever get aesthetically. So once you do a cadaver, you understand why. So that is the safest. Then there are two other techniques. That is, one is called just under the deep fascia of the muscle, and the other one is next to the bone. Those two injections, those two levels, which is we all inject that level. I do that. Stephen Liu does it. All the experts, Arthur Swift does it. All those two levels go through the plane where the artery is. So we ourselves are taking a risk of going through just like pray, which I say a prayer before I do. I do actually say a prayer before I do. I just say, oh shit, let me hit the artery. So we actually go through the plane where the artery is. Those are the planes that most experts inject. So that's how I inject. Arthur Swift, we inject in that plane, past the plane to the artery. But past, what does that mean? The artery could be in my way. Can you understand the dilemma? So the artery is actually in my way. I just hope the artery is not there, but it's in that plane. I just hope my needle will miss the artery. So this is a dilemma. So and if you inject in the superficial fat plane, this is outside the plane of the artery. So then you miss it, but you get a most horrible aesthetic result because it's too superficial. So that is my dilemma of injecting the temple. Whether the person actually know the risk or just inject blindly without really understanding or knowing that they have actually had to go through the plane of the artery. What I mean by plane of the artery, because you don't know in that plane where the artery is, so you still have to go through. So you just hope the artery is not in the way of your needle. Does that make sense without going through further detail? No?
I'll ask you a quick question. Why don't we use ultrasound to identify the artery in these situations?
Excellent question. Because the artery, I've done a study on there. I just posted last week about the superficial temporal artery. The artery is there, but the ultrasound that we have is a hockey stick. You can't pinpoint it. It's there. You will always find the artery, but you can't exactly locate exactly where the artery is.
Okay.
So it's not possible to do it. And so that's why injecting the temple is not as frivolous as easy as they say.
Yeah, Dr. Sham, you mentioned that we're in the plane where the artery is and you try and hope and you're not going to hit it. But you try and stay away from it, right?
You can't.
Where else?
You can't. You don't know where the artery is.
You don't know where it is. Okay.
You don't know where it is. You just have to assume it's in your way.
Yeah.
Just like the nasolabial fold. You can't. You know there's going to be a facial artery there, but how many millimeters off where your needle is, you can't tell. You just have to assume it's there. And in the temple, every time we inject, we have to assume we've gone through that plane. You can't avoid it. It's there. It's not to say that you have to assume it's there. Okay. Any other questions regarding this?
Oh, one thing. If you hit an artery, you will know straight away.
No, you don't.
There'll be a bruise.
No, you don't. You've gone through the artery, you don't. And I posted an article about, it was by Greg Goodman, a good dermatologist in Victoria, was written in the article Consensus, you do not aspirate, because aspirate is seen to be futile. That's his argument, which I totally agree. Most of the experts don't, when we teach not to aspirate because it is a false sense of security and is actually useless. So when you go through an artery, remember it's only 1 millimeter, it will bruise later. You actually don't know that you've gone through an artery because you've gone straight through because your needle is too sharp. And aspiration is not part of the practice. Any other questions? So let me talk to you about this case, which involved me. So there are many lessons to be learned from this. So this lady in stage 1, this lady actually was injected by a nurse, belonged to a in clinic, name remain unknown. Well, I can't disclose that. So she had lip filler. Right? I said, look, are you sure you had lip filler? It was lip filler. So of course we can't find out the technique. So this is her own photo. She had it injected on a Friday. And on a Saturday, she noticed some bruising here. And nobody took notice of bruising here. She sent a photo to the clinic and Saturday morning. This is her photo. So then she said, the person she contacted, the manager, wasn't a clinical person, and just said, okay, it's just bruising. I look at your record, it's just bruising. So that was on a Saturday. So this is again her photo. So on Sunday, her pain became quite severe. So she went to ED, and ED had, by the way, she lived 5 hours from Melbourne. So she went to a regional ED. We got no idea what she had done, because he just said, add a filler. You guess the resident knows what a filler is. So she went to ED, and ED just say, look, you better see your doctor tomorrow morning and give you some painkillers. And on Monday, she contacted the clinic again, went to the GP for some painkillers, because that's for casualty, and stage 3 she went painkillers, and this was her photo, right? So they said, you better, the GP said, here's the painkillers, we really don't know what to do. She contacted the clinic, and the clinic, that was on a Monday, and I wasn't told until stage 4. I wasn't contacted by the clinic till Tuesday evening. I walked out of the restaurant, I got this call, can you see a patient for us? I said, sure, what's the problem? It's a bruise. So I said, okay, I'll see you tomorrow morning. So when I saw the patient, that was 5 days later on a Wednesday morning, this was the case. So you saw me injecting hyaluronidase on that morning. It took me 1 hour to finish injecting the whole lot here. It was extremely painful. By that time, every part of this was super tender. And then, of course, I follow up the patient. Unfortunately, she lived 5 hours away, so she couldn't come. And I got her to record for me to show the capillary return. And this was a week later when I saw her. So the scabs are forming. There's not much I can do other than putting on antibiotics and hyaluronic acid. So there were many lessons to be learned from this. I gave a talk on this a number of times. It's through a series of steps that this has gone wrong. Is probably due to the process and procedural were wrong. The person who was injected was not contactable. So that was the biggest problem on a Friday. Next day, it was reviewed by, not reviewed, but given advice by a non-clinical person who looked at the picture. If you ask me to look at the picture, on the picture, I'll say, yeah, it's a bruise, right? Maybe a bit of pain, sure. The problem was that this patient wasn't reviewed face to face. So if you show it to me, I would have definitely missed color changing on this, because I only get one picture. What do you expect? You don't expect me to pick everything up. If you send me this picture, I would say, yes, probably bruise. But I would have said you have to see someone that day. So this could have prevented problem, because you could have taken somebody could have taken a more serious note and showing the bruising extending beyond the lip. If you show me and if I don't study it carefully, I'll say, yeah, it's a bruise, because I can't see the discoloration much there unless I'm pointed out. So in this case, on a Sunday, this happened on a Saturday. They talk to a manager who is non-clinical, but even if it's clinical, if you send me this picture, I may have missed it. If you happen to be ringing me and showing me the picture when I'm having lunch, and this is one on the pictures, then I put myself at risk in giving advice, because it just looks like bruise to me as well, right? But there were warning signs. But how many of us actually look for, like, where was the lip injected? It was injected here, but how do you explain the bruise and necrosis here or color change here? And I would have missed the nose color changes altogether, right? So, I mean, it can happen with anyone who just look at the photo, and that's my problem. And that's the problem. So it's a process failure with this one. So what to do with this one? Well, it doesn't show you, it doesn't tell you much that everything is gone wrong with this one already. But sent to an ED, they have no idea what you. They got no idea what a filler is to an intern, right? Let alone a scripting doctor. Where is the problem? So you have no idea where the problem is. Well, the problem is that somehow the superior labial artery got backflow into the nasal labial fold area, but how did it happen? I'm not sure, because I still haven't been able to talk to this. How did the injection here end up backflow to here? Or where was the entry? So all these are difficult to ascertain. Just like the nose necrosis. It's very difficult to ascertain exactly what went wrong with the technique. But we don't have time for that to know what went wrong with technique. And within a few weeks later, another doctor rang me, showed me the similar picture of a lip injection that crossed halo and discoloration here, and he immediately highlights, and I follow up the patient, and it was okay. So this could happen to a lip injection. So what I'm saying is, Raquel, you say, oh, I don't want to script high risk area. Well, it's your call to see whether lips is considered as high risk. But honestly, lips is probably the most common injections being performed. But this is not to do with the lip injection problem. This is to do with the process failure, that it wasn't follow up. The patient wasn't follow up. It can happen to me. I'm not saying that even if you script me, I could still cause a necrosis. So it's not the nurse. I can still do that. But it's a question of process. It's a question of follow up. So do you understand? So every time you inject, is always a risk. In medicine, you can prescribe somebody a cough and cold tablet, and they can end up having something else. It's part of our job. So it can happen to me. It can happen to anyone who's doing a lip injection. So I wouldn't dare to say that I'm so good that it doesn't cause complication. Yes, it has caused complication, but this is the case that you need to follow them up. It's a process failure. So at that time, by that time, you hopefully don't get, by that time, so, you need to know your aspirin, you need to know your painkiller, you need to know that you may have to have a choice of hyperbaric oxygen. It's still questionable whether hyperbaric oxygen, but if you live in metro area, then patients should have a choice. I'm talking about here, stage 3. I'm not talking about stage 1 and 2. Stage 1 and 2, you don't have to worry about hyperbaric oxygen. Stage 2, you can argue whether you can use hyperbaric oxygen. If you're in Melbourne, you may be expected to. Depends if you have to show up into a panel. Then they will say, why do you consider it? Everything is easy in hindsight. But in this case, even I didn't consider hyperbaric oxygen. It just, I tested her. She had full capillary refill. I didn't even think about hyperbaric oxygen. Should I? Yes, in hindsight, if I have to face a medical board, I'm sure they will pin me for that. Guaranteed. They'll say, because I took over the case then, right? So it's not the nurse injector problem, it becomes my problem. I compounded on the problem because I gave, that was my advice, right? So if she didn't recover, yes, I'll be pinned for it. Why did I consider hyperbaric oxygen? I should have. Eventually it became this. So prednisolone to reduce the swelling and the inflammation, Caflex, aspirin, and possibly hyperbaric oxygen. So Eventually, she scarred permanently, side of the nose. I didn't show in this one, but she scarred here, and she scarred here, and she scarred here. So as you can see, this area is very deep. When I saw her, I already told her that she was scarred here, most likely here. I didn't hear, So here you can fix. Here is harder, and this is definitely very hard to fix because there's not much skin and fat there. So, okay, so this is a good time to discuss what you want to know about skin necrosis.
Any other information about the patient, Dr. Chan, regarding her risk factors or surgery to the face? She may have had some temple surgery. Any other procedures to the face or smoker?
Not that I know of.
Oh, okay.
I didn't ask. I can't remember smoking. Not that I know of. So you're thinking about prevention of this problem. Even I could have caused this necrosis. Even I'm a very experienced injector, but even then, I wouldn't say I wouldn't cause necrosis. I will say that in this case, the lesson is what you need to deal with it within 24 to 48 hours in person somehow.
Sorry, so with the hyaluronidase, whereabouts did she inject? Or where she injected?
I will come to this next slide.
Okay.
Any questions, Andrew? No. Okay. Oh, good.
Yeah.
So the process is for 24 to 48 hours. It is quite unreliable even for me to look at photo. That's why I comment very carefully when I'm asked an advice, which happens all the time. I ask for a video, a capillary refill, because I can't see the patient. And pain is definitely an indicator. The pain should be decreasing after 48 hours, not increasing. That's another thing you need to know. So it should be decreasing, not increasing. If you inject somebody, they should get better 48 hours and not increasing, not crescendo pain. Okay? So that is something that you... So this one is the protocol, hyaluronidase, and you should know the mixture by now. I have this stuck on the wall because I seldom do it, and when it happens, I say, how many mils do I get? So I have this stuck on the wall because I can't remember, and because you don't do it all the time. I know how many units, but I cannot remember this mixture, okay? So I got this stuck on the wall. We have posters, by the way. We have this poster. So you have to stuck on the wall because I also can't remember. I said, because if I don't do this a lot, I say, how much should I make? So we have this emergency box here in the box, and my nurse will check the expiry date of the hyaluronidase. Okay, so that is the protocol. The protocol is one area is 500 units, and in this patient is 1,500 units because she had 3 areas. She had 1, 2, and 3. Okay. A lot of people, when you see the notes, and especially nurses, they say, I flushed the area. Oh my God. Flush is not very scientific. You need to know exactly how many units you've given. Not flush the area for your medical record. There's no such thing as writing flushing. Okay? So you need to know how many units you've given. And it happens to, like I said, don't think that it hasn't happened to me or us, my clinics. It happens. So when it happens, we get someone to video it and just test the payload capillary refill as part of my medical record, part of the medical defense. So I actually have to press it and, not press quickly, at least 5 seconds and let go. Not quick like that, you always see them pressing like that on the YouTube. Is so funny. So you actually need to compare with the other side as well for medical record to say, okay, is adequate capillary refill. So you actually should video it the whole process because something has gone wrong for your medical protection. So you inject 500 units to one area, so a total of 1,500 units in this lady. When it happens immediately, actually most nurses are pretty good. They because this message is so loud that everybody fears it, and the first thing they do is to high laser, and that is a sensible thing to do. If you are in doubt, you just high laser it, right? So most nurses, I must say, are very sensible. They know it because they fear it, and they've probably done my course, so they fear it, and so they high laser it. So if you want to wait, you can, provided you are there to see the client the next day. So it's not too late to high laser it within 24 hours. Certainly 48 hours is still good, but after that, it's difficult. After 24 hours is reasonable. After 48 hours, some damage will have occurred. Some skin necrosis, part of the skin would have caused damage. So, like I said, if this is followed through, injection is quite okay. It's only blindness and stroke you can't prevent. But necrosis, it happens to the best of us. I can tell you that now. Happens to the best injectors. It's just that you just don't know where the artery is. But I'll highlight another case in a minute. So this is something that you need to be aware of, and you, like all nurses who inject, must ensure they have the higher urinary protocol, and they know the protocol, so they don't need to ring you for permission. They just need to do it. There is a chance of anaphylaxis with high uronidase. This is very arguable. Some people say it's so rare that you don't need to worry about it. But in our consent, we tell the patient for filler consent, we don't have time to ask you for consent. Should it happen, we're going to inject hyaluronidase immediately. So there's a chance that you may suffer allergy, but it's in our consent. So we actually want that because we know it can happen to me or anyone. Okay, so you don't have to worry about it. Happens. It happens to the best of us. So make sure that it is in the consent, that it's possible for them to be allergic. There was again, I posted another article, I think last year, in my Facebook group, my doctor's Facebook group and nurses. It was this lady in London in London, your grandmother, my grandmother, anybody can inject, okay? So they don't have regulations there. So anybody can inject in London. They are the biggest user of hyaluronidase because everybody inject. It's just so crazy there. So you don't have to be a nurse, you don't have to be a doctor, anyone can inject. So what happened is that this lady had a lip injected, and of course, I can't remember the story, whether she didn't like it or whether she had blockage. I think she didn't like it. So anyway, didn't like it. So someone dissolved it, and she ended up anaphylactic reaction in the hospital. So she said, I went in for lips and then I got more trouble than what it is. So it does happen. If it is an elective hyaluronidase, then you definitely need a consent, or you do a skin prick test. I didn't put the protocol here. There's a protocol regarding hyaluronidase. There's a poster that you have to follow through. It means that you should and must do a skin prick test before you get to cover yourself medically. So because of that. But in emergency highlights, it should be included in your consent. That should it happen, you don't have time to sign for consent. You just need to highlight it. April, any questions?
No, totally agree.
What if patients not only live far away, but say they're going on a flight to holiday after their filler?
Always happens, isn't it?
Yeah, you don't ask them. They go to Bali the next day.
No.
We do say, some from groups we work with, a lot of those groups will say on their consents that you should not have treatment for 2 weeks before you fly.
Yeah. Okay. Great.
Look, it happens to me as well. People go back to China.
But they lie.
like exactly.
Yeah, they go back to China. They want to do this or whatever. I've injected people who go on the plane. So, but you have to take it. He says there's an emergency. I can't treat you anyway. So But yeah, you just make sure your process is okay, that you are contactable, and so on. Any questions regarding this?
Luke, what's your general approach?
Very good question. Most people will know where the needle went in, but with the needle, it could go in some fair way. And so, really, the idea about the VO, vascular obstruction, is that it can cause an embolus. So you actually need to where the needle is, and the whole area. It's actually the whole area. We tell you don't just inject where the needle went in. It's actually the entire area, because it's a microembolus that we worry about. So you basically have to dissolve the whole area.
Anywhere where there's a color change, you have to put highlights in.
Yes, the color change, and probably beyond that, because there's no harm anyway. So you want to dissolve the whole area. Yeah. So, but to put it in perspective, April said correctly, the chance. Look, over last 5 years since I've been running this emergency thing, this is the only case that's gone wrong. Most lips will heal even if they occlude. Like I said, most nurses are very, very worried about this, especially when we train them. They will just highlight it anyway. So most of them are quite sensible. And I posted another case this last week, whereby somebody put numbing cream and it cost Baylor.
I've seen that one. I've seen that one out there. Maybe it was on your page, Ben.
Yeah.
I have. Yeah.
It happened to my nurse, right? Put the numbing cream and the whole area turned pale. So again, my nurse was, sensible. She still injected anyway because she knew the risk was low anyway. So the risk is very low, and like I won't be wrong if I say 60% of injections happen in Australia happens to the lips, because that is very easy, profitable, and it's most people need it. So it's a very the chances of causing problem is actually quite rare. But I do need to scare you, right? Because doctors always scare you. What is the worst can happen, and get your procedure in place. If you get your procedure in place, you're covered from every angle, because you are safe. You know what to do, because there's no such thing as nothing can go wrong. Even appendectomy can be wrong. So you just need to follow the process. And time to deal with all this is within 24 to 48 hours, and not longer. In terms of technique, you for those who are injecting, you just need to run parallel to the artery rather than just bang straight into the artery. Is to do with the training. You just got to do with parallel to the artery, and not aiming for the artery. The artery is there. It's about it. It's about 4 millimeters deep in. But what do you mean by deep in? Where is the 4 millimeters? Because it's 3D. So the artery is there. All these arteries are there. So the question is whether you know how to deal with an emergency. So the only thing you don't want to do is to have an embolus that you can't revert, which will be the nose and the temple and the forehead. Because if you shoot off an embolus and cause a blindness, it's very hard to chase it, because it actually involves in the blindness. I might as well touch on that now as a discussion. There is still no protocol regarding what should happen, because we've got regional Australia, like this lady who came 5 hours away, and we've got somebody who lives next to the hospital, so it's very hard to set up a protocol that way. Should it happen, the injector must first inject highlights, okay? And then bring the notes. Well, you don't have time to write the notes. Bring the filler, what if it injected, together with a bottle of hyaluronidase, and bring the patient to the hospital. You don't call the ambulance. You do not send them away, because when they arrive at the triage, you're going to be stuck there for 3-4 hours. So that's again, it's to do with the process. So you got to you hopefully you know where to send to. In Melbourne, it's not a problem. Royal Victoria, they already know the protocol, and Sydney Anya Hospital, I do not know about other states. So by the time they go there, you can ring up if there's time on the way. Hopefully there will be a ophthalmic surgeon or ophthalmologist waiting for you, because they should know the protocol already. If you go into a hospital, not even the hospital, not the main hospital, they got no idea what to do. So the receptionist is going to have a hard time understanding what your problem is. And the resident is going to take hours to come in and see your patient, got no idea what is happening. And you can imagine, and finding the right person to inject retrobulbar hyaluronidase can be challenging. So can you see the problem? So you have to know that it's going to be a problem if you have to jump hoops like this, because it's just impossible to go through public hospital unless you got a good private ophthalmologist that's on call for you, so you can arrange that. But I'm in Melbourne Metro, so I'm lucky. Well, not so lucky. I hope I don't get any of this. So I inject nose, temple, and the forehead a lot, because being Asians, these are our highly sought after areas, right? The Asians always the anterior cheek, which was the facial vein, the nose, and the chin, and then the temple. So I do this a lot. So I'm in a very high risk category. So in terms of blindness, you simply need to be aware of the process and be prepared. So work out if it happens. If you script a nurse who does temple, because you got no idea whether the nurse actually know what layer of the temple they're injecting. Most of them can't even tell you. Even doctors, most of them can't even tell me. That's what I teach in USA and India. They are dermatologists and plastics, but they got no idea which level they're injecting in. So just be prepared. That's what I'm saying. If you're prepared, it's fine. But it will just happen to any of us, because we're in a high risk situation. Any questions, April? No. Andrew? Okay, I will tell you my experience. No, it's not HCCG, HCCC, sorry. I had a Asian patient, who came in and wanted the ear trough anterior cheek, and this is a problem. So it's very common for Asians to have a depression in area 4 here. So, and yet it's close to the intraorbital area here. So that was the injection. You talk about 7-8 years ago, when this was the reason why I started writing up anatomy, because out of my own curiosity, I actually didn't know what went wrong at that time. But of course, now I know what went wrong. So this is an anterior cheek. Now, when we go to training, we always do the lateral cheeks. The lateral cheek is the first training by anyone is always the lips and the cheeks, because these two are the highest sought after area in the Caucasian area. If I go and train in Asia and in India, you can forget about lips. They'll be wondering, why am I teaching them to train about lips? Because the darker the skin, the thicker the lips. So I would have no business training Indians doing lips, right? So, but in Caucasian, these are the two areas. Number one sought after area. In Chinese, with the East Asian, is always this area, the anterior cheek, because we're all flat, the chin and the nose, because that gives us the 3D effect. So when we inject in this area, in the lateral area, the deepest one you can go is the bone, which is a zygomatic bone. You can't do any damage, okay? So there may be a zygomatic facial artery. The worst you can do is just a bruising. That's about it. So you can inject that area fairly safely without causing any problem other than bruising. So when it comes to that injection of that Asian lady, so that was 600 years ago, I injected this area here. And next day, she came to me, I think it was I injected her on a Friday. she came to me. She said, "Oh, this area swelled up." I saw her in my clinic on Saturday. Good boy. So it was quite tender and swollen. And I thought it would be a bruise more than anything, more than obstruction. So I injected the hyaluronidase, and circulation was fine. There was nothing wrong with circulation. It's just red. It was just red and tender. So it was, in hindsight, it was definitely a bruise. So in this area, the bruising could have been caused by the infraorbital bundle, which I doubt, because if I inject into the infraorbital bundle, the patient will have numbness in the whole area. She didn't have numbness in the whole area because the nerve will be there. So in hindsight, I would have pricked the facial vein which comes up under the maxillary bone. At that time, I didn't know much about anatomy because under the maxillary bone, that is an area that's not protected by anything. So if you go there, you're actually aiming at the facial vein. Okay, backtrack. So I injected her. So I said, look, I'll see you on Monday. She didn't turn out on Monday. I had a record of my communication with her. We used WeChat. So on Wednesday, I said, look, I must see you. She didn't come in. And on a Friday, again, I said, look, I must see you. It was all recorded. I say, I must see you to make sure everything is okay. She didn't turn up. So after 1 week, you don't turn up twice. I told you to turn up once. I made the appointment. It was on the record. I say, I'm going to see you, I think something like Wednesday, 11 a.m. Confirm, yes, okay. She didn't turn up. So I chased her again. I said, look, I must see you. She didn't turn up. So the matter, I thought, was over. Then what happened was, 3 months later, in between, she said, wish me Merry Christmas and all that, very casual. I don't talk personal to my patients. I don't say, how are you, how's life? I never say that. It's all very straightforward. How are the things? Are you happy with it? Then I don't say, how are you, how's the family? I keep myself strictly professional. She was in her early 30s or 20s, so anyway, strictly professional. And this helped me to get into this saved me from trouble later on. So 3 months later, I got another message from WeChat again, say, what are you going to do about my case? I said, what? She says, I want compensation. I say, oh, in that case, I have to refer you to my insurance. It was very short and very, just say, oh, I'm not going to deal with this. But I say that, okay, I'm going to have to refer you to my insurance. Can you please send me the what you're after? You can send me the request, and then I'll pass it on to my insurance, right? Because she asked for compensation first time. Money comes into it. So went on he says, I went to the hospital. So I said, okay, just give me everything you have. What did the hospital do for you and all that? Then she went silent. And I said, what the crap? She's probably lying about the hospital, right? So I really didn't want to deal with the details anymore because someone asked for compensation. You immediately have to refer to your insurance and not try to communicate and make things even more complicated. That's what I did. I made it very professional. In case, yes, please send me the information, and then I will send to my insurance company, my medical legal insurance. So that was how I kept at it. Again, very short, but to the point. So I got a letter from APRA. Okay, so the process went like this. She wanted compensation. She probably found it too hard to fill in the form for write a complaint. She was Chinese woman. I don't know whether she will have any problem signing it. So then I got a letter from APRA. And this is what you expect to get from APRA if you ever get it. Okay, so it's a standard form that they send out to everyone because cosmetic practice is one of their highlights, that makes a day. So, what training have you got? Send me all the notes. That's number one. What training have you got in this area? And CPD points regarding this area of what you're doing, and all the education and continuous education you have. So, of course, I send it all to APRA, And my insurance, the first thing my lawyer from the insurance say is, Ben, everything looks in order. The only thing is that they may scrutinize or criticize you regarding your brevity of notes. I am one doctor that graduated 40 years ago. Think how much notes I write. Right? You guys write an essay on these things. For me, it's like two-liner. Inject here, draw diagram, shaded here. That's it, right? So they're gonna pin you on it. Look, if you scrutinize all the graduates from my era, they all have this common problem: writing too short notes. So you guys don't have that problem, but we do. It's just our practice. When we first started, we did on the A4 card. Just on cards. How much notes can you write on those cards? We were brought up that way. So, cut a long story short, it went along, right? They actually investigated. Actually, patient did go to the hospital on the Saturday, the following week, and had an MRI to show that there was no filler there, and so I got a feedback from APRA and say, look, no action. That's all they say, no action. They don't say any more things, right? My God, you went through all this trouble for no action, but I was quite confident that there was no problem, but I still couldn't be sure, right? What the heck did she go to hospital for? But when it came, then I found how thorough APRA went through the notes and investigation. I couldn't believe it. They were looking for a needle in the haystack just to penalize me. They gave the patient so much benefit of the doubt that I had to be guilty even before I was proven. So this was APRA. That's why there's a APRA reform. They went through, honestly, the communication they had with the specialists in the hospital, it was incredible. First of all, they took the notes from the GP who said, this is probably a blockage. So that already got the patient up against me, right? He said, it's a blockage. So send to the hospital. Again, you can see the same process, what went wrong with this one. Same process, right? Even though I highly remedy safe, patient safe, but went to the GP, said, this blockage, what do you think the patient would do when she hear that from another professional? Say this is a blockage. So my lesson to you is keep close contact with the patient. Don't let them see. It's almost like Dr. Lenses that tell you not to see another doctor. They come up in his Dr. Lenser, the one cosmetic surgeon. So he said, no, don't see someone else. Because I can understand it. Because to someone else, they can't understand the problem. So you try to contain it within your group and try, but in this case, it just went outside my control. Okay, so she was, so she went to the hospital, and guess what? The plastic surgeon is not one of my favorite. Of course, he would do MRI. What else would you do, right? You end up in the hospital, admitted under his care in a public hospital with my God. None of them dare to take a risk. Why would you admit someone like that? They didn't know what was going on. This lady probably crying pain. I don't know. It's an hindsight. So she got admitted, the MRI, and of course the specialist, at least he did a decent thing and say, look, we couldn't see any problem and discharge her with antibiotics, right? But you can see a series of things that have gone wrong. It is just not my lucky day, but it's just that this is the process. So anytime when the complaint comes in, usually it is patient dissatisfaction. And on my notes, I proved that I actually took care of the patient. APRA is only concerned with one thing and one thing only: safety. Okay, they don't care about your compensation. They want to know your safety. That's all they want to do. Rest HCC. In New South Wales, called HCCC, Health Complaints Commission, whatever. They got another C. I don't know why they got another C. So Health Complaints Commission is more interested in patients' satisfaction. So there are two different bodies. But as long as a complaint comes in, as long as you are a APRA, as long as you are an APRA practitioner, registered practitioner, you are under then you fall into the jurisdiction of APRA. It's not to do with HCCC. Okay, HCCC, if they receive a complaint, it's usually about, I want my money back, I'm not happy with the service, and so on. Immediately they will refer you to APRA. Immediately they will refer you to APRA because you are one of the members. So HCC, the first complaint will go to the HCCC. I want my money back. I'm not happy with the service. They didn't do what they say they do. We don't look at the complaint further. They just shoot it to APRA, and APRA only look at safety. If it is just a money issue, they just say not our jurisdiction. You deal with it. Having the best practice, it still landed me into sort of potential trouble, because APRA was really looking for a excuse to hang me. Whatever they do, they always say you're guilty, even though I wasn't. So that's APRA. They always think the worst of our members. So this is a process that went on. It can be, even though you're a safe injector, a good injector, as long as you are protected with good records, safety, you don't have to worry about it. You don't have to worry too much about things that could go wrong, as long as you practice safe medicine. So that is what you have to define for yourself. What is safe medicine? That's something. But most of the time, had the lady been compensated early, like I refund the money, she didn't ask for a refund. I would have gladly given her a refund because I caused the problem. If I had given her a refund, and usually as we stop there, we don't overcompensate, and that would have been the end of the matter. So that was a real problem. It's just one of those that slipped through. Okay, any questions?
Where do we write our notes? Where did you go? Do you have a set of notes, Dr. Chan? If you
I do. I don't use best practice. I used to. So now it's all in my in the skin clinic, because skin clinic uses a separate software. Mm. But if you are scripting, then just write in your BP or your medical director, whatever. So write that.
We've got on the new platform. We've got a space to write notes, Tom, for the script side of things. It's at the bottom of the page. You can put whatever you want in there. Yeah. There's a pre-filled out one you can select. It's pretty generic. Yeah. Basically, just says the nurse has told you everything, and it's a really simple, straightforward procedure. Or you can free text it.
Yeah.
Did the whole process take very long from beginning to end when they come up with the conclusion?
Yes, the whole thing, like, we didn't do anything for about 9 months, so APRA takes that long. They are really thorough, I can tell you that. I got a 50-page investigation. They're really thorough. They were really out to get me, I can tell you that. Looking at it is like the Spanish Inquiry, they're really out to get me. No questions?
So you follow up the patient. I would do it on a regular daily.
I did, but
alternate daily until they're happy.
Alternate, yeah, till they're daily. You try to appease, like
completely happy.
But in this case, I had to show APRA that I actually showed that I cared for the patient. She didn't turn up. What do you want me to do? Yeah. But then she went to the hospital and saw one of my, somebody who didn't like me too much, and make the whole thing even bigger. So the GP already stated that she got a blockage. What do you expect the patient to do? Yeah. It's not the patient's fault. And then went to the hospital and met someone who didn't like me and my competitor, and do the whole thing even bigger.
Yeah. You need to sue that GP. Defamation.
So he gets a 50-page.
Yeah, he gets the same.
So it does happen. Shit happens.
Oh.
Any question? Okay, so let's summary of what I've done. Okay, I've done everything right and still went wrong. Okay, so notes. You guys know how to write notes a lot better than I do. You must know the hyaluronic protocol. Actually, not use so much an injector because they are the first. You just have to make sure they know. Because if they know what to do, then it's not your problem. But if you don't know what to do, and it is going to be your problem because they don't know what to do. You're under supervision. You're not there. So, April, all the nurses, they know their hyaluronic days protocol by the back of the hand, and it doesn't go to the next level. If they don't know this hyaluronic protocol and when they should inject, like you say, Tom, when inject, take it out. Okay, when in doubt, take it out. So you save yourself a lot of problem. Otherwise, just if you inject the hyaluronic days, it's only a patient dissatisfaction. You can move on. Being available is super important. So that is more to do with the nurse, injector, or the company, whoever. You must be available. In my case, can you believe me or not? You actually won't believe what goes on. The person who contacted me on a Tuesday night, the injection happened on Friday, is actually the top of the food chain. He was the owner, and he was a doctor. Okay, he was top of the food chain, and he was told only on a Tuesday, right? And he rang me at 7 p.m. as I walked out of the restaurant. I was in the restaurant about this case. Like there are 4 days, and it didn't go. The process was very wrong. It didn't go up to that level. And when the whole thing settled down, when everything, the lady's left with the scar. I still haven't fixed the scar. I haven't fixed it yet. She lives so far away. And when the thing settled down, which means that she was left with a permanent scar, I couldn't get to contact the nurse to find out. From my point of view, I want to know how a lip injection happened up to be causing so much trouble. I actually was curious to know about her training and also the technique that she used. And guess what? The company said, no, it's better if you don't know. So I still can't speak to the nurse. And the excuse is the nurse is a very nervous person. Oh my God, I haven't learned anything. In 2 years, I haven't learned anything because I couldn't speak to the nurse. I couldn't speak to the injector. So, this is, funny things happen in our industry. Be very proactive, like me. Chase the patient. That is what I mean. That saves you problem, right? You just chase. Hey, are you better? You better? You better? No answer is to consider that you're fine with that. So if you can see, you can do all these steps. You're fine. So it's very rare. I wish and I hope it will never happen to any one of you. It's not, but you can see when all the black stars line up, I got into trouble and that guy got into trouble. When all the black stars all lined up, in the perfect constellation to screw us. So everything went into trouble. But it won't happen because you will always have someone like me or someone to protect you. So it won't happen. So Andrew and all that will always look after you, so you don't have to have a problem. And even we downplay the problem and don't say, oh, you got a blockage. That will send the patient 100 miles an hour to the nearest hospital. We don't downplay. We are professional. We say this is what it is. That's what you have. And to hear from one of us, look, this had to hear that it can happen even to the best of me. Even though I'm a trainer and I'm an experienced injector, very advanced injector, they get a sense of relief. Oh, it can happen to you too. Well, unless it's a red flag that we're dealing with or PIA, right? Who's looking for trouble. But most of the time we play it down and say that's what it is. We just have to fix it. And majority of the time they say, okay, thank you, doctor. It's nice to speak to someone higher than, they always want an opinion. But if they ring me out and say, oh, dear, you've got a blockage, immediately they'll be on the phone to the other. So his words are very important, right? It may be a blockage, but I'm still not going to say that. We're going to have a look. We're going to fix it. So you say, oh dear, it's a blockage. It's how you communicate with the patient. You do not want to escalate it. So I'm always here for you guys, so you don't have to worry. I sometimes have to ring the patient and say, hey, what's going on? So it's okay. Even the toxin, they say, oh, okay, they can load my earful on me, but I can still take it. So I know what to do. So anyway, I'm here for you guys. Okay, CPD points, we've done it. It's absolutely must. If you inject in an area, the APRA hasn't caught on to it yet. The insurance company now is, whether you are trained in all these areas that you are injecting, because now they're getting smarter and they're saying, oh, I'm not covering you this, I'm not covering you that. They need to know a certificate of training. And like I said, I'm not doing sales talk, but if it happens, Galderma is not your trainer, Merz is not your trainer. They're only your facilitator. Make sure you are well certified and well qualified to do it, to do this. Otherwise, just think yourself upskilling, so you know. Any questions up to this point? Okay, let's briefly talk about the areas that you will need to be aware of. So the superior labial artery, the upper lip is usually the main problem. Is usually not the lower lip that is the problem. It's usually the upper lip. And from the chin, I don't have anatomy here. The chin is quite a common and a safe injection if it usually causes bruising. I have only seen one case of necrosis. I've got no idea how it happened. You've got the mental artery, mental artery, submental artery, and the labial mental artery. So all injections should be carried out in the midline and on the side with a cannula. So this is the one thing that you do. It's quite only one rare case of necrosis. Most of the time it's just bruising. So bruising, we just have to accept that it is bruising. The lips, like I said, is the superior labial artery that runs up here. It has happened twice. Like I said, one happened to a doctor, one happened to the nurse. I show you. I really cannot explain how it flowed back there, but even the doctor assured me that it's a very experienced doctor. How it just flew back and just go up there, I do not know how, but it did happen. Usually it's the upper lip that's a problem. It's seldom the lower lip. And the lips are very, very vascular, which means that they heal super well. And provided you just don't block the artery here. I have seen many bruises, necrosis. I honestly, necrosis of the lips, I myself have not seen it. And, the lips is very vascular. I believe that even if you bit a massage and it will spread it out. But anyway, it's to do with technique. I have never blocked it. My staff has never blocked it. So although VO is commonly happen, it's usually not in the lip area. That's where you script. So it's quite a safe area. The marionette area, again, because there is a facial artery going up and then the inferior labial artery coming up. Here is usually bruising. You can't really block it. I have never seen any literature on blockage there. So this is the area. Nasolabial fold requires special training. To us, we require special training. I don't need to say much. Most people think they know, but I can also tell you most people don't know that they don't know. That there are 3 different planes to inject. Most people, I have seen a very, very, very experienced dentist asking me. She blocked the artery. She showed me the picture. It was definitely VO, but she knew how to highlight it, so that was averted. Problem was averted. She was a super experienced injector. But the problem is that they get trained only on one type of injection, and that's where the anatomy comes into it. They really don't know the anatomy in this area. And that's why if you inject 100 times, one time it will happen to you. So this was quite quickly averted, the problem. And because she highlights it, like I said, if you take action early, that's the end of the story. Nobody complains about it anymore. That was the end of the story. So it will happen to her. It will happen to her again. And I can tell you, it can happen to me as well. So just be prepared. Just be prepared. This area here, which is the anterior cheek, very common. the nurse should know the difference between lateral cheek and anterior cheek. So just up at this point, you've got the infraorbital arch bundle. If you inject it, nothing happens. It's just patient will get numb in this part, like your dentist. And numbness, they're all clear anyway, so 4 hours to 6 hours because of the linear cable they use. If they inject here, this will happen in my case, like bruising if you hit the vein. And below the zygomatic arch, which is here, below the maxillary bone, is quite common in Asians, is again, we call these, there's a huge facial vein, about 3 or 4 millimeters going up there. So you are looking for trouble if you do not know, if you inject below the maxillary bone and totally unaware the facial vein being there. What happened? It did happen to me about 8 and 10 years ago, way before I wrote the anatomy. The patient came out with a golf ball. It was so big, the bruise, it wasn't funny. Actually, even at that time, I didn't know what happened. I just said, oh, you're bruised. But in hindsight, I would have punctured the facial vein. It was a massive, massive, massive bruise. So, like I discovered now, 10 years later, what happened. But I really, at that time, my knowledge of anatomy was so bad that I just didn't even know the danger there. So that was what happened. Huge golf ball there. Tear trough, I don't think you inject a lot, or nurses inject a lot, but for the injectors, is the biggest problem with injecting tear trough is selecting the right patient. And even if you have right perfect patient, things can still go wrong because of patient dissatisfaction, not from complication, either too much filler, too little filler, swelling up, not enough. That is the highest area of complaint of the entire face from patient dissatisfaction. So it doesn't matter even if you tend to underfill, patients say, look, I didn't see any difference. So that is technically challenging. In terms of danger, superiorly, you've got the eyeball. Inferiorly, you've got the infraorbital bundle, which is not much. This is the one you need to be aware of. Immediately, you've got the angular artery going up. And again, training is super important because when they say, oh, I checked the tear trough, I don't know how I hit the angular artery. Because they were not aware of it, they got no idea where it is, and neither do I. It's somewhere here. Again, training is super important. If you inject enough, you will get into trouble. This one is don't worry about pubic promela, don't worry about these three. Brow augmentation is very common in Asians. Again, to do with which is 17 area here. Brow augmentation is just straight to the bone. Nothing can go wrong. It's almost like area 3, which is the bone. So that nothing can go wrong. Not even a bruise here. But if you go brow augmentation immediately, that is high danger zone because the superior orbital artery and supratrochlear artery all come out here. So this is high danger zone. So we won't talk about that. Temple is, again, you need to be an advanced injector to inject the temple area, which is quite common in Asians. We do that. This is, again, is glabella part of forehead? Yes and no. So this is danger. We do treat glabellar lines. Those superficial burning technique. Again, it's got to be trained. If you're not trained, you've got no idea what you're doing. And the forehead this is for advanced injectors only, so I won't go into that. The temple area is a very high risk area. This temple, the temple area, number two area, is a very high risk area. Because of the frontal branch superficial artery, it goes through there. So you can imagine if I were to go into the bone area, which after Swift is very common area, to touch a bone, you just hope you miss this artery because it is there. You just hope and pray you just gone past. Even if you go past it, you will go past it. But what happens if you go past it, nobody knows. So it is there. You can't avoid it. It is in your way. It's in the way of your needle. So lastly, I want to talk about the nose. This is an area causes us a lot of problem. I inject nose a lot. Get proper training, and we advise the injectors who want to learn about forehead, temple, and nose to attend cadaver courses because this will highlight to you, help you to visualize what is going on underneath. Okay. So when they say inject a nose, I have this problem with an Indonesian doctor who contacted me a year ago during COVID. He injected the nose and it caused necrosis of the whole area. Again, this case was posted in my Facebook group last year. It caused necrosis of the whole area. And that's a lesson to be learned. Number one is he said he injected there and the tip. The anatomy is very different between 6 and 7. It's got to do with your technique, how you inject it. And having done a cadaver will help you to conceptualize what I'm talking about. Injecting at the base of nose, yes, one case been reported where it wasn't just under the nose, it was more towards the inside. And guess what? The filler came out the other side of the inside of your mouth. If you put your tongue up there, that's where it is. If you put your tongue up, so if you are not high enough, your filler will come out the other side, necrosis on the other side. So again, it's got to do with understanding of the anatomy and injection technique. You can't just do injection technique without seeing cadaver. You can't do cadaver without following the injection technique. So it came out the other side, caused necrosis. Again, I posted this. The nasal tip is a common place for necrosis, very much the same as glabella. It's to do with the injection technique. The nose, we inject a lot, even Caucasians. So you inject whether you cannula or nose, we will describe that in the workshop. So this area is quite, if you work in Asia, there's no aesthetic doctor that doesn't know how to inject nose. I can tell you, nose is probably the first area they learn how to inject. Because every Asian that comes in need the nose done. So they do it the reverse. They don't need the lips. They don't know how to do the lips. And even they know how to do the lips, they don't have the experience of doing lips because no one asks for lips. So the nose, on the contrary, is done millions of doses in China, Asia, Taiwan, Southeast Asia, whatever. So if you come to my aesthetic training practice in Asia, the first thing you learn is the nose. And this is one of the worst things you can learn is about the nose, right? So we encourage them to do cadaver so they understand the different technique to inject the nose. So what we teach here and what we teach overseas is quite different because their emphasis is on the nose. They say, oh no, I'm not going to script anyone to do the nose. There they do noses every day, all the time. Every day they have 3 or 4 patients doing the nose. So it's not as scary as it sounds, but yes, it can lead to blindness, so we sign consent. So there are 2 ways. You can use a cannula or needle. And when I use a needle, I always inject lidocaine with adrenaline, so it blanches it. There's very little chance of me causing necrosis. Those are the little trick that you do. But we have to see your technique. Because when I say the nose, all people go all the way up there. So again, it's to do with training. Like this lady here, so she only needs up here, okay, from the radix to here, if she wants it at all. I don't think she needs it. But there are people who have a takeoff from here to here. These are what we call avatar nose. All the European ladies, Middle East ladies have the avatar nose. Okay, they come straight from the nose to here, right? That is a look. You look at all the Middle Eastern ladies, they all have a very high takeoff. Only Asians have this radix. So all the Middle Eastern ladies have this, okay? So if this lady wants to raise his nose, then you have a problem. Because if you're not trained, because the nose is just from here to here, not higher up. That's already the glabella. So if you try to inject here, which is here, you're asking for trouble. So again, it has to come from training. It's got to come from understanding anatomy. So he said, no, I've been shown nose that if you inject up here, you're going to ask for trouble. Okay, so this is very quickly around the nose, which has caused a lot of grief in the Western world because they are not trained properly. And yet, this is something that we train almost elementary in Asia. So this is my take on nose. Nose tip. This Indonesian guy injected nose tip and nose, and I believe the obstruction caused necrosis very much similar to this lady, except not down to here. So this whole area was necrotic. The side of the nose, upper lip, but not the side of the mouth. So what went wrong? So I said, yes, you need to just follow the protocol. So he said, yeah, I follow what you've done. And yet, again, this was posted last year, I think, in the case. And yet, this lady ended up necrosis with a scar in in this part of the nose, in her, okay, I didn't do it. In her forehead, she had scar. The side, this one she had scar, and the side of the nose, she had scar. So I couldn't understand. He contacted me within 48 hours. So I said, can you send me your protocol exactly what you did? Okay, remember, the protocol is 500 units, 500 units, 500 units. So she will have combined 1,500 units, right? No, that guy only injected 50 units. I said, what? And this was months after. I said, wait a minute, I thought you read my protocol. You know the protocol. So I didn't know that until months later that he only injected 50 units. I said, how do you work out 50 units? I got no idea how you made 50 units, but he only checked 50 units. He said the lady was in pain. Okay, I have no more words. I can tell you, injecting this lady took me 1 hour. She was so tender, so painful. So, again, this was due to mismanagement within the first 48 hours. Had he followed my instructions of injecting 1,500 units, that lady would have been fine. So, here's the thing. You really need to know your protocol and don't be afraid to inject. Look, it's not going to happen to you, I don't believe, but I'm just sharing my history and my experience. Unless you want to be an experienced injector, then you will face what I do, but by that time you'll be super good already anyway. So you don't have to worry too much about that. This is what happened. So this is a protocol. So any questions so far? I think that's about it.
Yeah, with the on the issue of pain, if you're high lasing in an area, would you do that 1,500 units per day and then come back and reevaluate?
Okay. The protocol is 1,500 units every hour until you get flushed.
Every hour.
Every hour. So don't send a patient home. In terms of pain, again, look, I've learned a lot by teaching. Yeah? So I don't. Sometimes your head can't be straight and you just can't think. This lady, like I said, your question mark is hyperbaric oxygen. Okay. So it's arguable this area now starting necrotic, 2 days, libido lenticularis. I think it does call for hyperbaric oxygen if it's available, if you're especially in Melbourne like me. So there's no excuse for me not to do it. And you can review the patient the next day. I can bet this area is going to get worse anyway, even despite high runny days. So what you can do is that you want to improve the circulation, then you start to use heat packs and all that to improve the circulation. But if I'm living in Melbourne, if I'm being strung, there's a case for hyperbaric oxygen for those pain in the ass, people panel. But most people wouldn't know, but you never know. You have one of pain in the ass on the panel and say, look, you should have done hyperbaric oxygen. So I will be strung. And somebody else suggested, like in this lady, right? It was really tender. I think you got that video in the thing. It was really tender. You touch it, oh, she jumps. Somebody suggested that I could have done an infraorbital block to inject this. I'll leave that to you. So, possible, but I don't want to give them, I don't know. My infraorbital block is not that good. I don't know about you. So I'm not good at dentists, so, my dentist do perfect infraorbital block, but not me. Questions? No?
No.
April? He's gone. Okay. I think April's gone. So, look, this won't be the end. I can give you my number, or John can, April, or whoever can give you my number. It's very important that you stay in touch with me to make everything safe. Like, I as with typical of all medical lectures, it always make the worst out of things. Probably never going to happen to you 99.999% of the time. But in case at times something happens to you, I'm just at the end of the phone line. I travel a lot, but if anything, you can WhatsApp me. I'm always available to you. If you run into any problem, whether you or your nurse, I will hold your hand and I will take responsibility. And sometimes, if it's transferred to me, then I can sometimes help you smooth the problem up for you without you getting a headache. Sometimes you may not know. Just just make sure that your process is correct, your notes is correct, your high run the days protocol is correct. Be always available to your nurse or you. Be proactive. Keep chasing the nurse. Tell you doesn't mean it's over. Keep chasing you until it's over. At the CBD point, whether you want to do cosmetic medicine or not is up to you. Okay. So my last message is to you. I'm always here for you. So whatever happens, just give me a ring.
Thank you.
Thank you so much.
Thanks.
Okay. There's always I can learn from you and you can learn from me. So we can always learn from each other.